morning. Welcome to the Stroke Special Interest Group Student Corner. Cicely and I are excited today to discuss with you Part 4, the examination of an individual post-stroke and her after we've reviewed her Gait assessment video. I am Heather Hayes. I'm the chair of the Stroke Special Interest Group. I am located out of the University of Utah as an assistant clinical professor and very excited to be sharing with you today. Please welcome my guest, Cicely, and she'll introduce herself.
Hello, my name is Cicely Fabiano. I'm a first-year student physical therapist at the University of Texas at El Paso. I'm happy to be here.
Great, thank you, Cicely. So just to summarize what we've done so far in the Student Corner is we started with an individual who we observed walking and did a gait analysis. On our next visit, after we talked about that patient, we hypothesized what might be some of her impairments. On the next visit, we discussed what might we want to assess. So at this point, we have taken our individual through the entire ICF model. We've talked about body structure and impairments. We've talked about functional limitations and also participation level. So what we're going to do today, we realize that this individual is somebody who has a desire to improve their mobility, because her primary goal was to keep up with her children or teenagers when out in the community. So one of her primary goals relates to what we would consider being able to assess the core outcome measures. When we think about what the core outcome measures are, the clinical practice guidelines were established a couple of years ago, and they can be found on the Academy of Neurologic Physical Therapy clinical practice guidelines. The core set of outcome measures will provide you with information about the full guidelines, also some quick references. But it turns out that there are 5 outcome measures that are recommended be analyzed for individuals with neurologic disability, and also for individuals who have a desire to improve their balance and walking. So we find that we have the Berg balance, the functional gait assessment, the activities balance confidence scale, 10-meter walk test, 6-minute walk test, 5 times sit to stand. And when you come to this webpage, you can get your pocket cards for interpretation of the core measures, how to perform the measures. You can watch videos on the Synapse course modules that are free. Great way to learn these measures. And so what Cicely and I are going to do today is we're going to talk about the knowledge translation report card that is specifically related to these core outcome measures. So I'm going to show you what a report card will look like, and we're going to discuss aspects of this report card. So when we look at your report card, this is a great way to help you guide your patient and provide them feedback with how they're doing on their progress. So Cicely and I were able to, we evaluated this patient in March 21 of 2021. And what we found as we measured her on these different areas, her comfortable walking speed, fast walking speed, 6-minute walk, Berg, the functional gait assessment, balance confidence, and her 5 times sit to stand. So we have these measures initially, and what we're interested in doing today is identifying what might be the goal that we would want to set for this individual. And what Cicely has done is gone to the literature to find out what type of change we might want to expect and what might be our goals that we are seeking for her to achieve. And this will help guide our treatment. We may find that she's already doing okay in some areas and may not need to improve that. Probably some areas that we're most interested in, though, are her walking speed and her walking distance, since her goal is to be able to keep up with her teenage daughters. So Cicely, let's take, for example, we found that this individual was able to walk at 0.72 meters per second. And I'd like to, can you inform them kind of what the student's next step might be to find out where one could find the changes to make?
Yeah, so we want to, in the literature, we want to find first in this measure the standard error of measurement, and then look at the minimal clinically important difference, meaning the amount of change that will signify an actual improvement for this patient that we care about in the clinic.
Fantastic. And so the area where we would go to look this up would be, you can Google the 10-meter walk test and under the Shirley Ryan Ability Lab. It's formally called rehabilitation measures, and as long as you put in those right words, you'll get to the assessment. Sometimes it's hard to go just to Shirley Ryan, so put in the words that you want. I will also caution that 10-meter walk test is a very specific outcome measure, and sometimes what you'll get is just gait speed, so be sure you're choosing the measure that you're interested in. So what I like about this webpage is it basically has done the homework for you. It states the purpose of the 10-meter walk test. It states what it's assessing: functional mobility, gait, potentially vestibular. It tells you what type of measure it is. They're calling this a performance measure, and the cost is free. So we're going to go to the section down here that is specific to individuals post-stroke. They give us our populations. We're going to click on individuals post-stroke. So let's talk a little bit about what this means.
So that SEM, that's the standard error of measurement. And what that means essentially is that any score that the patient gets, we assume that there is some variability just due to simple measurement, uncontrollable error. And for this measure, that standard error range is 0.04 meters per second. So we need to have more change than that to assume that actual change occurred.
Fantastic. So our patient, if we go back to how she was performing, we found that she was performing at 0.72 meters per second. So if we assessed her again today, about a month later, and we said that she was now 0.72, then, or 0.73, then really no change has been made.
Right.
Okay. That was just our ability to capture that data on a stopwatch. Okay. So now let's go to what we do care about the most, is the minimal clinically important difference.
So there, beyond the standard error of measurement, we assume that actual change has occurred. But the minimal clinically important difference is the amount of change that research has come to the conclusion that we assume is significant enough to mean that improvement or digression is occurring.
Great. Okay, so let's keep this in mind, these three numbers, so 0.06, 0.14, and 0.16. So let's go back to our subject and look at where she was before. So as we're thinking about our prognosis of what score we might want to have her get on her comfortable walking speed, what would you anticipate or desire to have her make?
So we need that MCID, right? So the 0.72 meters per second, we want at least 0.16 meters per second of improvement beyond that. So that is coming to 0.88 meters per second. That's kind of our goal of improvement at a minimum that we want.
Okay. And now I would just clarify, so 0.88 would be a fantastic speed for her to achieve. And let's just go back to this again. I might want to say a substantial, meaningful change. Like, what would be a range? 0.88 might be our maximum.
Mm.
But what might be something like, okay, at least we know we've improved her a little bit?
Oh yeah, so that small meaningful change, if we add 0.06 seconds or meters per second to our 0.72, so 0.78 would be like the minimum meaningful change that we would like to see, and then up to like we said, the 0.88.
Yeah, great. Now let me ask you one other question, a little bit tricky. When we look at this literature, it does say in 2010, the mean age of these subjects were 63 years old, and they were assessed at approximately day 20 and day 60 post-stroke. How does that compare to our subject?
So our subject, she is 45 years old, so she's almost 20 years younger compared to the average here, but she also is she's a chronic stroke patient, so she is 12 months post-stroke still. The younger age may give her potential for greater improvements, but the chronicity may take away from some of those greater improvements.
Fantastic. Okay, so let me just show you one other area that I really like, why gait speed is so important to us. So we were kind of shooting for her to be able to be a 0.78 to 0.88 improvement. So here's what we find, and this is from Perry et al. In 1995. This is just a great way to help people estimate what they may be able to do. If someone walks at their self-selected pace at less than 0.4 meters per second, they're likely to be a household ambulator. That means that they can probably get off the couch, go to the bathroom, but they're going to have a harder time going out to the post box if it's down outside. A limited community ambulator from 0.4 to 0.8 suggests that they are going to be able to maybe walk into the grocery store, but maybe not a lot more once they can hold onto the cart. But then when you're a community ambulator, this means that you can walk over grass and up and down stairs and feel fine ambulating in the community, whether you have an assisted device or not. So right now, our individual falls in this limited community ambulator. And this might be what she's experiencing. Teenagers are at soccer games, and she wants to be able to get out on that soccer game fast enough, not to have to keep and run up with them on the soccer field, but she wants to be able to get there and not have a problem to do that. So when we think about what we're trying to achieve in our game, we're trying to get her up into this community ambulator. So initially, our minimum was 0.78, our maximum was 0.88. So I'd be happy if we can get her to around 0.81 at her self-selected pace. Okay, so now let's go ahead and come back to our report card. Just to kind of clarify that this report card, we may sit down with her and say, look, I really want you to improve this. It definitely states that based on data from community dwelling and or healthy older adults, these are our concerns. So if you say to her that this is normal for her age, I'm not sure that we'll ever be able to get her to that range. But as we just stated, if she does make an improvement, we can say that she's faster. And I would write down kind of for somebody who's had a stroke. And this is definitely something to keep in mind, less than 1 meters per second. She's not that, but may indicate a fall risk. So she actually would be somebody who will be considered a fall risk, but we're trying to make sure that we put all of these together. So it's not just walking speed. Let's go down and take a look at her Berg balance as well. Okay. We do want to caution our patients to always be safe, but that kind of gives us a sense that we want her to be able to go to up to 0.8 would be a great goal for her. Okay, so now let's take a look. We're going to kind of discuss these a little bit more and kind of give a prognosis. Based on the fact of her fast walking speed, tell me a little bit about what this means. So she's 0.72, but her fast is 0.95. What does that tell us a little bit about her?
It means that she can increase walking speed if need be.
So let's go next to our walking distance. So this is how far she walked in 6 minutes, and she walked 306 meters. If we were to convert that, just to give us a sense of what is her speed over time as she's walking a distance, what does that turn out to be in comparison to her comfortable walking speed and her fast walking speed?
So the 306 meters in 6 minutes brings her to the 0.85 meters per second. So if we compare that to her 0.72 and 0.95, it's kind of right in the middle there.
Great. And that's actually tells us quite a bit. So this is an individual who potentially has that capacity for community ambulation. Mm-hmm. And so a comfortable walking pace, like you and I both have a pace that's just may not be up to speed. We might just be more, kind of walking at just nothing that's important. But It sounds like she does have the capacity to push herself.
Yes.
So now, as I'm talking to her, I might want to know a little bit more about what the problem is. Does she feel like she doesn't have the endurance to walk as far? What if we were to do a 12-minute walking test? Would we start to see her fatigue? At this point, I would say we don't see some of those changes. So it makes us think, like, what's going on with her balance? Is there something else going on with her balance that might be a concern? So let's take a look, and I'm not going to show us on each category of rehab measures for the Shirley Ryan, but what does this score mean for standing balance? A Berg balance scale of 48 out of 56.
If you go to Shirley Ryan, you'll find that less than 47.5 out of 56 is deemed slow walker status.
Okay, and here we have that for older adults, 50 is considered a fall risk. Okay, so you mentioned the standard error was 2.5 for stroke. And let's just take a little bit for chronic stroke. There's another interesting point. Standard error of measure is 0.98. So 47, 48, 49. What we're interested in is the minimal detectable change for chronic stroke. And actually, look, this looks really good. So 58-year-old, that's close to our age. A 4.13 change for minimal detectable change. So we would love to increase her by about 3 points on that, 48, 49, 50, maybe 51. And here's where I was talking about for the cutoff scores. 45 out of 56 is going to indicate more of a fall risk, indicates high risk of falling for chronic stroke, less than 44. And as you mentioned, slow walkers. So this is something that I do think we need to get her up into the 50 points range to make her overall safer, start to get away, especially with aging, let's get away from that lower scores that might impair her ability. So we're shooting for a 50. And actually on those, I'm just going to let you know that probably her number one thing was standing on her impaired limb is going to be really difficult. So single limb stance, and she's probably falling low on that. So, but if we got her up to 52 and she could do tandem stance, that would probably be really helpful for her for both directions. Let's go next to, I'm going to come back to the FGA. Let's look at her balance confidence. What do we know about a balance confidence of 76%?
So 76%, the cutoff scores for that, the one I'd written down is that greater than 81% is considered no history of falls.
Okay, I agree. So this is something we would like to be able to increase. And what I like about this measure is if you look at it, it may be something like, obviously no one's comfortable walking on ice, right? That's why 81 is good. So none of us are like, but if she says to us, the number one area that I have a hard time with is in the winter keeping up with my teenagers, then that tells me that maybe we're dealing with uneven surfaces or slick surfaces. But it might just be, one of the questions that it asks is standing on a escalator while holding a package. I mean, that makes me a little bit nervous, but it is something that we could potentially work on. How do we get her into a dynamic setting of stepping onto something that's moving and gaining that confidence? So it's a great way to kind of figure out what might be some of her impaired confidence and why she can't sustain those walking mobility in all the different settings.
Okay.
All right. And then the last one here is let's do the ability to perform transfers through a 5-time sit to stand.
So she's at a 16.1. The cutoff for that, greater than 12 seconds, is indicative of stroke, and obviously we know that she did have a stroke.
And what does this score tell you a little bit about the individual?
It could be their lower extremity strength. We can get a little bit of insight into their balance strategies or their movement strategies based on their score.
Yeah, great. So if we find that she kind of does all of her standing up on one leg and shifting because of the hemiparesis, then we don't have a lot of power coming out of that leg. Mm-hmm. So agreed. So just to summarize a little bit here before we get into our dynamic balance, we have an individual who walks at a slow pace. We've already seen that she has a hemiparetic gait. She is able to speed up. That's fantastic. She has pretty good endurance, but she may need more. Her standing balance could be improved. And so it's not any one of these alone that needs to drive this discussion with her. It may be what type of setting she wants to be in, what type of confidence does she have. It may be that her biggest reason why she can't keep up with kids is decreased confidence. So we're kind of work on those, on what aspects may be contributing to that. And then she may have some reduced power that we would want to investigate a little bit more about her strategies. So all together, we're starting to get a picture of who this individual is, and this now is helping us guide our treatment, whether it be treadmill training to speed her up, whether it be more dynamic balance exercises, but we do know that treadmill training can improve dynamic balance. So there's a lot of things here that are helping us already tell us how to guide our treatment. So the last one I want to look at, because this is one of the hardest ones in stroke, I think, is your functional gait assessment. She scored a 16 out of 30. What is this going to do? This is now kind of putting all the pieces together and why this measure might be the most important one.
Yeah, so it looks at, I think, a combination of gait and motor tasks. So it's coordination, it's balance. I think it's similar to another measure, the dynamic gait index. Mm-hmm. But yeah, so the standard error measurement for this one is roughly 1.5 points. For the minimal detectable change is 5 points. So we would like to see her improve roughly to 20 if possible.
Mm-hmm. Great. And so if we got her up to 20 or 21, we're really close to that fall risk for healthy adults. Mm-hmm. And what we would find as you kind of look at this, one of the questions that's asked on that is, as a patient walks up to the boxes, do they have to slow down? Do they continue walking? Do they swing their leg? And she's most likely going to swing her leg or never step over with a hemiparetic leg, right? Bringing us back to, does she trust her balance, confidence on that? And so that's now, as we look at the pieces in that might be impacting her, we can start to draw all that together for where we want to make some changes. Do you have any other questions related to who this patient is and what our goals might kind of be for her?
So based on what we, the summary of this report card for our patient, would you find it more of a priority to focus on balance or dual task or coordination versus her, for example, her walking speed? Because we did find that she is capable of having a pretty decent speed in walking.
Mm-hmm. So great question. I would really, this comes back to a patient conversation that I would have. What is her primary, as we look at that? Is it stepping on grass? Is it uneven surfaces? So she might be a great one to put on the treadmill while pushing her at a fairly high intensity with throwing objects at her. So she has to react quickly. She has to step over those items. Is she really hesitant to put that left foot forward? It's her right foot forward on something when stepping over something. So gaining that strength would be so I would just give that to her for home exercise. We need that leg stronger. This is your homework. Your job is to get that stronger on your own so that we can come in and start to apply that to our function in the clinic. So she would be a really fun one to put on the treadmill at high intensity and giving her multiple objects in dual task. But that's now a dynamic task that she has to do. Mm-hmm. That might be one of those things that's going to be a little bit scary for her, and also letting her know that she can do that, like stepping on a moving sidewalk in the airport. Mm-hmm. And putting her in a setting where she has to hustle and bustle through something. If they're at the mall and she's trying to look at something plus keep up with her daughters, that might be that just environment that's really getting her. So how can I simulate that in the clinic? And those would be, as I look at each of those pieces a little bit more, I'm going to start to fine tune what might be the best treatment for her.
So we want to prioritize what her real life participation and activity goals are and treat accordingly. Okay. And then I had one other question. How often would we reevaluate and get a new set of scores for her?
I would try to do it every month. If I was seeing her twice a week, I would try to do it every month. And some people like to do them once a week. It kind of depends on how often you're seeing. I say every month because that would allow me to do a progress note.
Mm-hmm.
And it also gives them time to kind of see some change. It's very discouraging when you don't see the change.
Yes.
So once a month to me would be great. And that would also help me know, are we close, or do we get to go another month, or are we only going to go for 6 weeks, right?
Okay.
That's going to help me know, we're going to go 2 more weeks, or we're going to go 4 more weeks in our intervention. Okay. Well, I want to say thank you to Cicely for your time, and we hope that you can share this with other students and that they can come back and join us again for some other questions.
Yeah, my pleasure. Thanks for having me.
Thank you.